Hello, this is Russell, and in this video, we'll be running through the intubation preparation. We have our team members ready in the room. We've got the airway doctor, myself as the airway nurse, the sedationalist, the drugs and procedures nurse, the doctor team leader, and the nursing team leader who will also scribe and time. We also have a nurse to provide manual inline stabilization. In this case, we also had a family member outside the room able to observe through the curtain with a nurse as a designated support person. The tool that we use to ensure everything is in place is the SOAP-ME acronym. Stands for suction, oxygen, airway equipment, pre-oxygenation, monitoring and medication, and end-tidal CO2. So for suction, we ensure the anchor suction is on and working, and we have it placed in between the mattress and bed, as shown here. The suction is used to get rid of any vomit or blood or any secretions during the intubation. Oxygen, we've got two ports available. One will be connected to the non-rebreather mask, and the other will be attached to the bag valve mask, both on 15 litres of oxygen. Having two ports just ensures that we can easily swap over masks without having to disconnect and reconnect things. Airway equipment, we've got the CMAC, which is on and working. We've got two size 8 and size 7 ETTs with cuffs checked for leaks. Got a bougie, got two spare laryngoscopes with size 3 and size 4 blades with the lights checked, and our gel as well. We also have some adjuncts, such as the Goodell's, which has been measured from the incisors to the angle of the jaw, and an NPA, which has been measured from the tip of the nose to the tragus. We've got some tracky tape, some lubricant, and a syringe to pump up the cuffs. We also have a sphygmomanometer in the drawers, which can help us to check and adjust the cuff pressure. Pre-oxygenation, we've got a 15-litre non-rebreather mask applied to the patient, and this helps to get the highest possible oxygen saturations and prolongs safe apnea time and reduces the risk of a hypoxic brain injury. Monitoring and medications, we've got the cardiac monitor on, SATS probe on the opposite arm to the BP cuff, and we've got the CO2 monitor for post-intubation confirmation. On the side here, we've got our drugs drawn up. We've got some ketamine as the induction agent, and we have some rocuronium as the paralytic agent. We also have a bag of normal saline attached to a pump set, which can help administer the medications and flush the medications through. Here we have our morphine and midazolam infusion for post-intubation sedation. We have our ventilator on and ready to go. Um, we've got our settings, so SIMV, and we'll adjust the tidal volume to 540 mils based on the patient weight. We'll adjust our respirate to 16 to start, and we can adjust this based on the patient's CO2 levels. We'll also start with a PEEP of 5, and our FiO2 will start at 100% oxygen, which we can decrease based on the oxygen sats of the patient. We have our ventilator circuit set up here. We've got the inline suction, got an HME filter, a swivel, and the end-tidal CO2 monitoring as well. Now for positioning the patient, we've got the patient supine on the bed with the height as per the airway doctor. We are not ramping as we are suspecting a possible C-spine injury. So we've got a nurse here who will perform some manual inline stabilization. Before the procedure starts, we do a quick timeout to outline team members and their roles, go through the airwaves plans A, B, C, and D, and any anticipated events and to check allergies. As shown there, we've got the typical airway kit if needed.